Hello, and welcome to our training on the clinical features and diagnosis of schizophrenia spectrum disorders. This is a part of our Understanding Schizophrenia Spectrum Disorders series. So if you're interested in learning more, please go to the rest of the trainings in this series. Let's take a look at what we'll be discussing today and our learning objectives. So the goal is that by the end of this training, you'll have a better ability to use key terms and related to the diagnosis and clinical features of schizophrenia spectrum and other psychotic disorders, and then also incorporate an understanding of key features and symptoms to the work with individuals within care. So let's take a look at our two main sections for the discussion today. So the first section will be focusing on the presentation of and features of schizophrenia, and look at time course and symptomology, and discuss connection to other diagnoses, associated risks, and homelessness. And then the second section will feature on diagnosing schizophrenia. So the who and how of diagnosis, some of the diagnostic criteria, including duration, and a discussion of how you can mitigate bias during diagnosis. So our presenter today will be Dr. Mark Avery, who is a principal with Health Management Associates, who's a board-certified psychiatrist and a recognized leader in the subject of person-centered integrated psychiatric care. And as always, we have posted our material notes. So if you're wanting a closer look at some of the talking points or to click on the links, please feel free to click on the meeting material notes for more information. So I'll turn it over to Dr. Avery.
Thank you, Patricia. Happy to be here to talk to you about the presentation and features of schizophrenia spectrum disorders. We have a lot to talk about on this presentation, so let's go ahead and get started. This slide depicts all of the DSM-5 conditions that are listed in the Schizophrenia Spectrum and Other Psychotic Disorders chapter. All of the CARE Act eligible diagnoses are contained in this chapter. The content of this presentation applies specifically to schizophrenia itself. This is because schizophrenia is amongst the most common of the conditions in the DSM-5 chapter. However, much of the material also applies to the closely related conditions in this chapter, especially those of schizophreniform and schizoaffective disorders. The other conditions shown on this slide are all related in terms of having prominent psychotic symptoms, but may otherwise be experienced and appear quite differently than schizophrenia. The DSM-5 chapter of schizophrenia spectrum disorders includes many different diagnoses with similar sounding names, in addition to schizophrenia. These diagnoses are all clumped into one chapter because psychosis is a feature of all of them. Each of these has somewhat different diagnostic criteria, however. For instance, note that this list includes conditions that present similarly to schizophrenia, but may not meet the full 6-month criteria for a formal schizophrenia diagnosis. As noted, all CARE Act eligible diagnoses are contained in the DSM-5 chapter on schizophrenia spectrum disorders. However, the reverse is not true. Not all of the diagnoses in the chapter are eligible for care for the CARE Act. The two that aren't eligible are psychotic disorder associated with a general medical condition or catatonia associated with a general medical condition. If those diagnoses are present, they must be accompanied by another eligible diagnosis to meet criteria for the CARE Act program. Also, there are other conditions not in this chapter where somebody might experience psychosis. For instance, severe bipolar disorder with psychosis or severe depression with psychosis. Even though these conditions may feature psychotic symptoms, they are neither contained in the DSM chapter of schizophrenia spectrum disorders, nor are they eligible for the CARE Act program. And also keep in mind that having an eligible diagnosis is just one of the criteria for the CARE Act program. For instance, somebody with brief psychotic disorder, schizophrenia disorder, or substance medication-induced psychotic disorder would have to meet the duration eligibility criteria for the CARE Act program, even though the diagnosis does not require that 6-month time frame that the CARE Act program does. Okay, let's move on to the next slide, please. As we discuss schizophrenia spectrum and other psychotic disorders, please pay attention to the ways that our biases may impact the way we perceive those with a serious mental illness, and especially the intersection between serious mental illness and race and culture. People from different racial and ethnic groups are especially vulnerable to misdiagnosis and even overdiagnosis. That's especially true with Black Americans. Also, those in racial and ethnic minority groups are more likely to experience negative treatment outcomes, such as reduced symptom improvement, and may experience fewer follow-ups after diagnosis. As we talk about how these disorders present in our diagnosis, please consider the ways in which our biases might influence how we perceive individuals and how that might get in the way of an accurate diagnosis. Okay, let's go on to talk about a case example. I'd like to discuss a hypothetical person named Darren. Darren is a 28-year-old single male who lives with his father. He immigrated from Somalia to California when he was 15 years old. Darren was diagnosed with schizophrenia at age 18 after having an emotional breakdown in his first year of college. His first symptoms were persecutory thoughts and hearing voices around the school administration where he was going to school. Prior to the symptom onset, he was really quite successful academically, but unfortunately, these symptoms resulted in him dropping out of college. He's been a client at a local mental health center where he has received a regular counseling and an antipsychotic medication known as lorazepam. Darren has generally been stable at home. However, his father reports that despite the care he receives, he's leading a sedentary lifestyle and generally keeps to himself. 6 months ago, Darren started having thoughts that somebody might be trying to poison him, and thus he stopped taking his medication out of fear. Since then, his behavior has become increasingly erratic and has been spending many nights on the streets. Yesterday, he was brought to the emergency room after somebody found him walking down the street and appearing to yell out at imaginary persons. Darren's mental health case manager then visited him in the emergency room, where he appeared notably restless and afraid. His eyes appeared to dart around the room as if he was seeing or hearing things. When asked how he was doing, he responded somewhat nonsensically, saying, quote, "The CEOs, they know my name. The name is the game. The game is the answer, but they won't answer." When asked if he understands what's happening to him, he says, "Yes, I'm being poisoned." And then when asked why he was yelling in the street, he said, "I need to let everyone know the poisoners are here." The mental health case manager was appropriately very concerned about Darren and very empathetic to the distress that he was in, and was considering making a referral to the CARE Act program to help provide Darren with better structured care for him to get better outcomes. Okay, let's think about Darren as a hypothetical example as we go through some of the material later in this presentation with the next slide. Keeping Darren in mind, let's talk about schizophrenia in general. Many of us may have an associate, client, or loved one with this condition. But what causes schizophrenia in the first place? The fact is the causes of schizophrenia aren't well understood. This may be because there's probably not one single pathway that leads to developing this condition. Most researchers believe that multiple factors play a role, such as brain development, brain chemistry, our genetics, as well as other lifetime risk factors, including substance use, trauma, and other environmental factors such as stress. All of these things together may play a role in the development of this condition. It's thought that these risk factors result in alterations in transmission of certain neurotransmitters, the chemicals that our brain cells naturally release when they communicate with one another. With the next slide, we discuss how does then that translate into how schizophrenia presents. Let's first talk about how it begins in a person. Schizophrenia most typically presents in teenage years or early adulthood. Often, a diagnosis is made following one or more episodes of psychosis, and we'll define that word psychosis in a moment. The psychosis and eventual diagnosis of schizophrenia may appear suddenly without warning, as in Darren's case, or it could follow a prolonged period of nonspecific functional impairments, and this is known as a prodromal period. In other persons, someone may eventually be diagnosed with schizophrenia following what was thought might to be another condition, such as bipolar disorder, depression, or something else. So consider our case example, Darren. Remember that he was first diagnosed with schizophrenia at age 18 after having an emotional breakdown in college. This came on rather suddenly for him. That is, he had no prodromal period. His first symptoms back then were persecutory thoughts and hearing voices. He recently began having thoughts that he was being poisoned and stopped his medication out of fear. Keep in mind that although schizophrenia often presents in late teens or early 20s, referrals to the CARE Act program are more likely to occur a little bit later after initial symptoms occur and after attempts at less restrictive measures have been tried. As we move on to the next slide, we depict how schizophrenia may be experienced over time, or known as the time course of schizophrenia. It's hard to create a graph like this because the experience of schizophrenia over time is highly variable between persons, but it can be thought of generally as a chronic condition characterized by active phases superimposed on periods of residual long-term symptoms. Generally, you can describe schizophrenia in terms of three phases of symptomatology: the prodromal phase, active phase, and residual phases. The prodromal phase refers, as we mentioned, refers to the period of time before first recognition of disease. During this period, people may have nonspecific, subtle differences in behavior where they may feel out of place, have odd beliefs, have some unusual perceptual experiences, decreases in motivation, sleep disturbances, or change in emotions. This could last for weeks. It could even last for years. The second phase is the active phase, sometimes referred to as the acute phase of schizophrenia, where symptoms are most noticeable. This phase, especially the first time it happens, can be alarming to the person experiencing them and to friends and family. They can be highly distressing. The diagnosis of schizophrenia is typically made during one or more of these acute episodes, though there often is a delay, sometimes unfortunately for years, between the onset of symptoms and an accurate diagnosis. During the active phase, episodes are often dramatic and may include an exacerbation of their background symptoms. The residual period between the active phases is a period where individuals may still experience symptoms, but the symptoms may be less pronounced. They still may have ongoing beliefs that are odd to others. They may still have difficulty with concentration. They may even still have some hallucinations. Keep in mind that each person's experience varies. Schizophrenia generally follows a pattern of episodes, acute episodes of illness, oftentimes characterized by prominent positive symptoms along with negative symptoms, which we'll cover next. These symptoms, in both active phases and residual phases, may exhibit progression over time, especially if the person goes untreated. A major strategy in treating schizophrenia is to, on one hand, reduce the number, severity, and impact of the acute episodes, while simultaneously also trying to treat and reduce the symptoms of those background episodes. And as mentioned earlier, a referral to the CARE Act program typically happens after the person has experienced schizophrenia for some time and after less restrictive measures may already have been attempted. Okay, with the next slide, we delve into a longer list of the actual symptoms of schizophrenia. Schizophrenia is a complex condition that may present with one or more of actually a very long list of possible symptoms. To help understand these symptoms, they've been divided into two groups referred to as positive and negative symptoms. The terms positive and negative don't refer to in any way to anything good or bad. There's nothing good about positive symptoms. And they're certainly not meant to suggest that anybody with negative symptoms is doing anything wrong. They're not meant to be derogatory in any way at all. However, the APA defines negative symptoms as a deficit in the ability to perform normal functions of living, whereas the positive symptoms are an excess or a distortion of the normal function. So the negative symptoms that you might see or someone might experience are things like reduced motivation, impaired judgment, lack of symptom recognition, known as anosognosia, blunted emotions and affect, social detachment or social isolation, and cognitive impairments. The positive symptoms, on the other hand, are symptoms like hallucinations, delusions, paranoia, and disorganized thinking. We'll talk about more of these, about each of many of these symptoms in more detail. But in general, the positive symptoms of schizophrenia tend to stand out, especially when someone is in an acute phase of their illness. For instance, if somebody is responding to external stimuli by shouting in the street or expressing delusional or paranoid thoughts. The negative symptoms, on the other hand, tend to be less dramatic and can be even missed by clinicians and caregivers. However, the negative symptoms of schizophrenia are often just as troubling and difficult for an individual to experience, and although they are less dramatic, they're actually more strongly correlated with the longer-term functional impairments and challenges of this condition. For instance, consider how difficult it must be to maintain quality of life and adhere to a treatment plan if your motivation is impaired or you have cognitive impairments. These two symptom groupings, positive and negative symptoms, are not necessarily separated in time. For instance, acute episodes may present with both positive and negative symptoms, and the same is true during the residual phases. And as mentioned before, one of the goals of treatment of schizophrenia is preventing and treating the symptoms of the acute episodes while at the same time reducing the symptoms during the residual phases. Okay, delving even a little bit deeper with our next slide, let's talk a little bit about hallucinations. Hallucinations in schizophrenia refer to experiencing things that are not actually there. Of course, they can be highly distressing, very distracting, confusing, or even dangerous to the person experiencing them. Hallucinations are generally distinguished from illusions, whereas a hallucination refers to seeing or hearing things that aren't really there. Illusions are oftentimes just a misinterpretation of real sounds, sights that are in the environment. Both can be distressing, but hallucinations are generally more specific to psychosis. There are several types of hallucinations. Uh, the most common form of hallucination in schizophrenia is hearing things, such as hearing a voice or hearing multiple voices. But each person's experience of hearing voices is unique. They can be fleeting or they can be constant. They can be loud or they can be soft. They could be hearing singular or multiple voices. They might not be hearing voices at all, might just be some sounds. If they are hearing voices, they might just be benign commentary, or other voices might be perceived as somebody telling them to do things, known as command hallucinations. Not all hallucinations are in the form of sounds, however. Sometimes people experience visual hallucinations, also referred to as seeing things, that can occur in schizophrenia. These also vary a lot from person to person. It could just be seeing a fleeting shadow from the corner of your eye, or they could actually be more fully formed visions. Other senses might also be involved, such as you could have hallucinations that affect your sense of touch, taste, and smell, though these are somewhat less common. Looking to our example, Darren, he hears voices that he doesn't like to acknowledge or talk about, and he sometimes sees things that makes him uncomfortable and nervous. He's very uncomfortable about talking about these things with other people, and thus that makes it difficult to make an accurate diagnosis sometimes about Darren's ongoing experience. On our next slide, we talk about another prominent symptom in schizophrenia, and that's of delusions. Delusions are another common feature in schizophrenia and refer to constant false beliefs that are often bizarre sounding to an outside observer. For instance, someone might feel that that the body of a person they know well has somehow been taken over by someone or something else entirely. There are many types of delusions, however. Most common are what's referred to as paranoid or persecutory delusions that are the false belief that somebody is out to get them or hurt them in some way. But people could also have delusions referred to as ideas of reference that are environmental signs or media messages that are communicating some sort of message to the person. For instance, the idea that the television is talking about them personally. Grandiose delusions are the belief when someone has an expanded sense of self, an expanded sense of their power, their wealth, or their importance. And there's a type of delusion referred to as erotomania. That's the false belief that somebody, usually of importance, is in love with them. Grandiose delusions and erotomania can often occur with other psychiatric disorders, such as a manic episode as part of bipolar disorder. So that condition might be considered when prominent grandiose or erotomania delusions occur. Like hallucinations, delusions can be highly distressing and preoccupying to the person experiencing them and could result in the person engaging in harmful behaviors as an attempt to address the false belief. Looking again back to our case study, Darren, he experiences delusions and believes that somebody is trying to poison him. He recognizes that other people see this as a delusion, but he doesn't see it that way. And he gets anxious about it, and his anxiety can amplify the delusion and make him even more suspicious. Okay, the next symptom cluster I'd like to talk about is that persons with schizophrenia can often experience disorganized thoughts or behaviors, especially when in an acute episode of the illness. During these times, persons may have difficulty organizing their speech into logical sentences or staying on topic, and they need to do that in order to get their basic needs accomplished, such as, dressing appropriately each day for the weather or in preparing food or arranging for food. Persons who experience disorganized thinking of schizophrenia oftentimes have difficulty in communication with others, sometimes in order to even get their basic care and services. The disorganization can lead to some profound ongoing difficulty in even getting food, shelter, maintaining personal hygiene, and maintaining personal safety. Like hallucinations and delusions, disorganized thinking can present in a variety of forms. These include tangential thinking, where a person just loses the thread of a conversation and veers off from topic to topic to topic. A similar kind of disorganized thought is loose associations, where a person creates disjointed statements or thoughts that are often unrelated and nonsensical and difficult for both the person and to track and the interviewer to understand. Thought blocking occurs when statements that are incomplete and a person's thoughts just suddenly seem to drop off midway into completion. And with severe thought disorganization, you might actually experience what's referred to as word salad, which is a severe form of disorganized thoughts where words are mixed in a grossly disorganized and nonsensical way. Looking to our case example, Darren is generally coherent in the emergency room, but definitely demonstrates some loose associations in his speech. Okay, so those were several of what's referred to as positive symptoms of schizophrenia. Let's move on to the next concept and talk about the concept of psychosis. This term gets used a lot, and in fact, we're talking about today about the schizophrenia spectrum and other psychotic disorders chapter of the DSM. So what does that term psychosis even mean? Well, psychosis itself is not actually a diagnosis, but instead refers to a cluster of symptoms, including those that we just covered: hallucinations, delusions, and disorganized thinking. Psychosis can occur in many different diagnoses, not just the schizophrenia spectrum disorders. Persons who have psychosis are, of course, often in crisis. They may have suicidal thoughts, they may be highly paranoid, they may be behaving in a disorganized, erratic way, and they may even engage in risky, agitated, or aggressive behaviors. People who are having a psychotic episode are often highly vulnerable, and this oftentimes leads to a psychiatric hospitalization. The risk of acute psychosis is higher in persons who are not receiving treatment with an antipsychotic medication. Not all persons with an episode of psychosis have schizophrenia, however. Psychosis occurs with other types of psychotic conditions such as severe bipolar disorder or severe depression. A mental health professional is typical and needed to evaluate a person with psychosis to determine whether the symptoms are due to schizophrenia or to another condition. This is actually very important because a misdiagnosis can oftentimes lead to confusion and to providing the wrong treatments. Even worse, a mistaken diagnosis that is recorded in a person's medical record can often linger for years, continually clouding the person's treatment options. Thus, an accurate diagnosis from the outset is the optimal situation for somebody with psychosis. Also, even though psychosis can occur with other diagnoses, only those living with schizophrenia spectrum or other psychotic disorders in that class may be eligible for the CARE Act program. Okay, We covered a number of symptoms that are referred to as positive symptoms and talked about a definition of psychosis. Let's talk about a few of the negative symptoms that we mentioned earlier. First is the concept of anosognosia. Unfortunately, persons with schizophrenia may not be able to recognize or understand their own symptoms or illness. This is a phenomenon known as anosognosia. Anosognosia is often identified by clinicians in the mental status examination and recorded as a lack of insight or poor judgment when that mental status examination is documented. Whatever it is called, however, this lack of awareness makes it more difficult to provide informed consent, and it can make it more difficult to provide services and support and to engage that person in the appropriate care and treatment. The next symptom cluster I'd like to talk about is cognitive impairments. One important aspect, a clinical aspect of working with persons with schizophrenia is to recognize the real potential that persons might experience cognitive impairments. The cognitive factors such as reduced attention, working memory, and problems solving all can occur in schizophrenia and may require adjusting how treatments are provided. For instance, in an educational meeting, instead of covering all the potential side effects of a proposed medication option, the clinician may need and may choose to slow down and more carefully cover only one or a couple side effects at first, and check with that person's understanding of basic concepts before moving on to more information. One particular cognitive factor is worth discussing separately, and that is the potential for persons with schizophrenia to have impairment in recognizing key social cues in others, something that most of us are able to sort of take for granted that happens naturally. But in persons with schizophrenia, they may have particular difficulty in recognizing anger or sadness in somebody else and responding appropriately. Clinicians can help by providing special forms of cognitive behavioral health interventions to help persons with limitation to adjust and compensate for this difficulty. Okay. It's also helpful to understand that persons with schizophrenia are unfortunately also likely to have additional psychiatric diagnoses at the same time, a concept known as comorbidity. And like the causes of schizophrenia itself, the reasons why schizophrenia is associated with a higher risk of other psychiatric diagnoses is oftentimes not well understood. For example, somebody with schizophrenia, it's common for somebody with schizophrenia to experience significant depression and might even lead to a formal diagnosis of depression. But other persons with schizophrenia may experience mania along with their condition, leading to an additional diagnosis of bipolar disorder. Or that depression or mania may overlap temporally with the symptoms of schizophrenia itself. And in that case, if the overlap is significant, then the person's diagnosis may be changed to another diagnosis known as schizoaffective disorder, which is also, by the way, eligible for CARE Act. Persons with schizophrenia are also at high risk for exposure to trauma and thus could be at risk for developing symptoms of PTSD. And persons with schizophrenia are unfortunately at high risk of developing substance use disorder, including tobacco use. For instance, persons with schizophrenia spectrum disorders are 5 times more likely to use tobacco than persons without that condition. Of course, the presence of multiple psychiatric diagnoses oftentimes makes assessment of schizophrenia and developing a treatment plan more complicated. Um, but I'd also like to reinforce a point I made earlier, in that I'd like to distinguish between the concept of have the presence of having multiple correct diagnoses versus the risk of accumulating one or more incorrect diagnoses. As mentioned before, early and accurate diagnosis is important because misdiagnoses are unfortunately quite common and can lead to confusion and to providing the wrong treatments. And as mentioned earlier, a mistaken diagnosis that is reported in a person's clinical record can oftentimes linger for years, continually clouding the person's treatment options. Okay, at this point, I'd like to mention that for more information about the association between schizophrenia and other disease states and about clinical features of schizophrenia in general, please go to the CARE Act website where additional materials are available for you. Next, I'd like to talk about the associated risks and complications of schizophrenia. There are, unfortunately, other complications that persons with schizophrenia that may experience that are a result of their illness, in addition to the symptoms that I listed. In addition to treating those symptoms mentioned earlier, treatment and support of persons with schizophrenia is often focused to help reduce the impact of these various complications of the condition that the person could experience. First off, persons with schizophrenia oftentimes commonly experience depressed mood. A certain amount of sadness is very common in persons with schizophrenia, with or without a formal separate diagnosis of depression itself. People with schizophrenia may experience reduced self-care, neglecting basic elements of their diet, personal hygiene, or overall health. Unfortunately, persons with schizophrenia are at generally higher risk of suicide as compared to the general population. The overall risk of suicide is actually about 10%, and the risk is highest in younger persons and young adults with schizophrenia. Persons with schizophrenia may experience social detachment, letting go of important family, friend, and other supportive relationships in their lives. Maintaining these relationships is one of the important early interventions when working with persons with these conditions. Homelessness is unfortunately also a common complication of this condition. Consider that 30% of the approximately 500,000 unhoused individuals in the United States reside in California, and 25% of those individuals are living with a serious mental illness. Persons with schizophrenia spectrum disorders are also at risk for incarceration and involvement with the Justice Department. Persons with schizophrenia are at risk, as mentioned above, of substance use or dependence, and persons with schizophrenia have higher risk of poorer health outcomes, including early death. So let's look back at Darren again. The complications that he's facing in the vignette that I described are social detachment, reduced self-care, and his recent behavior may put him at risk of a legal involvement due to his walking down the streets as he was doing. As Darren participates in the care process, it's helpful to understand the full context of Darren's diagnosis and additional complications. Understanding these complications can help all members of the care team, including courts and counsel, to identify and eliminate our biases that may be triggered by these associated diagnoses, risks, and complications. While we're on the subject of risks and diagnoses, Move on to our next slide and talk about the connection to homelessness itself. Schizophrenia and other psychotic disorders are highly prevalent amongst homeless people, as mentioned above. A person's social detachment and paranoia associated with the illness can increase this risk of homelessness. And homelessness itself can exacerbate stress and thus the symptoms of schizophrenia. Persons living on the streets have huge challenges in being able to maintain hygiene, maintain a regular sleep schedule, and the ongoing threats of violence. All of this can add together to stress levels that can hasten the descent into psychosis and other symptoms of schizophrenia. And homelessness itself can make it difficult to access and maintain constant mental health treatment. All of these things can play a role in a person who's experiencing schizophrenia and homelessness at the same time. For more information on the relationship of homelessness to schizophrenia, please refer to the links in the slide deck for additional references. Okay, let's wrap up this section of the presentation, and let's take a moment to consider how Darren's individual circumstances might affect his clinical presentation of schizophrenia and his experience with the CARE Act proceedings. Well, first of all, Darren currently appears restless and afraid. Individuals supporting Darren through the care process should be compassionate and patient when interacting with him. Secondly, Darren is an immigrant from Somalia. Consider how his cultural practices and his personal preferences might impact his engagement in services and supports. He may also have additional trauma from his experiences of bias, and that may connect with some of his experience of being an immigrant from Somalia. Care team members should consider ways that they can use a trauma-informed approach to address this trauma if it's present. And possibly when developing a CARE Act plan or agreement, consider Darren's preferences. For instance, he recently stopped his medications due to concerns and fears he's had. It might be helpful to develop a psychiatric advance directive with Darren at some point that may help support him moving forward, both throughout the care process and beyond. Those are just a few of the ideas that occurred to me when starting to apply some of these presentation concepts to Darren specifically. Okay. That concludes the first part of our presentation today. And now we're going to move on to the second section of our presentation. Where we'll be talking about the process of diagnosing schizophrenia. Let's start with who can diagnose someone with schizophrenia. Schizophrenia is generally diagnosed by a mental health professional who is trained in the use of the diagnostic criteria for this mental health condition, those criteria that are contained in the DSM-5. The diagnosis is made by collecting information and talking to the person, and after all other possible causes of the symptoms have been ruled out. This is depicted in our next slide, which is a fairly complicated slide, and I'm going to take a few moments on this. In this slide, you see a funnel. At the top of the funnel, all of the information that is collected when we're assessing Darren is put into this process. That information includes history taking, talking to Darren, talking to his family members, talking to other caregivers, looking at the medical record, taking a detailed medical history, taking a psychiatric history and a substance use history. You may also examine Darren to assess his overall health and possible related physical conditions. And in the examination, you conduct what's called a mental status examination, which is a detailed assessment of the patient's emotional presentation, his cognitive functions, thought processes, mood, and perception. And you might actually do some laboratory or toxicology tests to rule out other metabolic or medical conditions. All of this information is then put into the funnel, and where it is analyzed and synthesized, a process known as formulation. So you put all that information together and start saying, how can all of these, concepts, symptoms, and signs that we talked about and discovered earlier, how can all this stuff fit together? That's a process known as formulation. The formulation then goes on to create the differential diagnosis, where the clinician says, okay, here's all the stuff that we discovered about, let's say, Darren. Here's all the stuff that we discovered about Darren. What is the list of all possible diagnoses that can account for all of these symptoms and signs? And as you'll see in the notes, the list of the possible things that could explain the symptoms and signs could be quite large. Could include substance-induced conditions. Could include other forms of psychosis, such as mood disorders with psychotic features. It could be other schizophrenia or psychotic disorders in the schizophrenia chapter. Or just could be other psychiatric disorders in general. But it's important to take that step to say, what are all the possible diagnoses that could be at play here? And then that list gets boiled down to what's referred to as the final diagnosis. But it's important to know that sometimes clinicians are not able to make a formal final diagnosis right away. This situation is known as diagnostic uncertainty. And there are a few ways to manage and document this uncertainty. For instance, in the clinical record, you can document that the diagnosis is provisional, or you can select a more non-specific diagnosis while other more specific diagnoses are being ruled in or out. For instance, in Darren's case, he presented to the emergency room with what appeared to be an acute exacerbation of psychosis. The emergency room psychiatrist obtained as much history as possible, reviewed the physical exam and the available lab testing that day, but did not have access to all of the clinical records to verify that other causes of psychosis, such as bipolar disorder, were ruled out. They formulated their findings as an acute episode of psychosis and listed the possible diagnoses in the differential diagnosis. They ultimately diagnosed Darren as unspecified schizophrenia spectrum disorder or either psychotic disorder until more specific information could be obtained. So, how do we get to that more specific diagnosis of schizophrenia? What are the requirements for this? Well, schizophrenia, as I mentioned, is diagnosed by a mental health professional who's trained in the use of the diagnostic criteria in the DSM-5. The diagnosis is made by collecting information and talking to the person after all the other possible causes of the symptoms have been ruled out. Keep in mind that there's no actual blood test or brain scan that's used for diagnosing schizophrenia itself. Tests and other procedures like this are often ordered to rule out other conditions that might mimic the symptoms of schizophrenia, such as delirium due to infection or other medical causes. The DSM-5 outlines the following symptoms that are part of the diagnostic criteria. Those include delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, or negative symptoms. At least 2 of those 5 symptoms must be present during a significant portion of time during a 1-month period, or less if successfully treated. And at least one of those symptoms must be the delusions, hallucinations, or disorganized speech. And persons must demonstrate a social or occupational dysfunction. In other words, the experience of these symptoms can't be trivial. They have to have one or more major areas of functioning that have declined because of this experience of these symptoms. There are also specifications about durations, which we're going to discuss next. The DSM-5 stipulates some criteria related to duration of symptoms are required for a diagnosis of schizophrenia. For schizophrenia itself, continuous signs of the disturbance must be persistent for at least 6 months, with an at least 1-month period of active symptoms, including, as mentioned, delusions, hallucinations, or disorganized speech. During the prodromal or residual periods, the sign of the disturbance may be manifested by only negative symptoms or by active symptoms that are less pronounced. There are also some specifications about exclusions and distinctions, and we'll cover that next. The DSM-5 describes several exclusions and distinctions from other conditions for a diagnosis of schizophrenia. To be diagnosed with schizophrenia, the following criteria must also be met. First of all, you have to rule out that schizoaffective disorder and standalone depressive or bipolar disorder with psychotic disorders have been ruled out, because either no major depressive or manic episodes have occurred concurrently with the active phase, or if the mood episodes have occurred during active phase, they've been present only for a minority of the total duration of that period. You also have to rule out that the psychosis isn't due to a substance use condition. That would make the other diagnosis the correct one, or a general medical condition. Again, an alternate diagnosis would be correct. And it can't be related specifically to a pervasive developmental disorder. These criteria help clinicians to make sure that they're not misdiagnosing schizophrenia, that is actually a different diagnosis in the DSM. With our next slide, let's return to the concept of mitigating bias during our diagnosis. In a few of our other trainings on mitigating bias and trauma-informed care, we've talked about how bias can influence our ability to make an assessment. Implicit bias can impact our assessment when diagnosing schizophrenia spectrum or other psychotic disorders as well. There's a bunch of ways that we can work in order to reduce the likelihood or impact of these biases. And these are listed here on this slide. They include, first of all, using standardized diagnostic criteria that we apply to all persons. Clinicians who do psychiatric diagnosis, oftentimes, most instances, complete cultural competence training. It's also important to just be aware and be self-reflective of your own potential biases and how they might affect your judgment with an individual case. Second opinions can help to reduce our bias, especially with colleagues who have special expertise in working with persons from different cultural and ethnic backgrounds. Taking a patient-centered approach, improving our education and training on bias, using clear and effective communication, all can help reduce our bias, as well as careful documentation of our rationale for making certain diagnostic decisions. Okay, let's wrap up the second section of this presentation with our second ideas and action slide. Once again, let's go back to our case example, Darren. Imagine you are doing an outpatient psychiatric intake with Darren. Remember, he immigrated from Somalia about 15 years ago. He has persistent thoughts that he's being poisoned and is very fearful. You speak to both Darren and his father. You welcome him and you conduct a quick safety assessment. And you now feel that you're ready to start doing a general assessment with Darren. Here are some general questions to consider. First of all, how would you describe his fears that he will be poisoned? What words would you use to describe them? Are they delusions? I would say yes, they most likely are delusions. Remember, delusions are fixed false beliefs, not just fears. So you'd have to collect that information to verify that this isn't just a fleeting thought, that these are actually ongoing delusions that he has experienced. If they indeed are delusions, what type are they? Are they grandiose, erotomanic, persecutory, or paranoid? Well, if they are delusions, they're definitely of either the paranoid or persecutory type. However, if they're not delusions at all, they might just be simple anxiety, flashbacks, or something else. Okay, here's a bit of a trick question. You review the record and see that Darren was diagnosed with schizophrenia previously in another state, not California. But you can't verify when or how that diagnosis was made. You're not a say you're not a psychiatrist or a psychiatric diagnostician. Is it okay for you to rely on that diagnosis? It's a bit of a trick question because the reality is you really should never rely on a previous diagnosis, especially when you cannot verify what information was utilized in making that diagnosis and or what bias those clinicians might have had when they did that. This is how erroneous diagnoses keep getting carried forward in chart. The best approach would be to conduct or arrange for a careful assessment to verify that diagnosis. Okay, another sort of trick question. You look at the record and see that Darren was previously diagnosed with major depression with psychotic features and not schizophrenia or one of the CARE Act eligible diagnoses. But you don't think that diagnosis is correct, and you'd like to see Darren be enrolled in the CARE Act program. What might you do? In this case, again, you might consider requesting a formal diagnostic reassessment by a mental health professional, such as a psychiatrist, who's licensed and experienced in treating similar conditions. To clarify, maybe Darren might actually have one of the CARE Act eligible diagnoses. Okay, after a couple of visits, you're fairly confident with your diagnosis. But you also note that you're not really that familiar with Somali history and culture. How might you take steps to mitigate your potential bias in your diagnosis of Darren? Well, in our last slide, we covered a bunch of things that you could be doing. One of the things you might consider is getting a second opinion, such as from somebody, from a clinician who's an expert in Somali culture, or by using standardized testing and or learning more about Somali culture and history yourself. Okay, that was a lot of information. And with thanks for all of your attention, I'd like to pass the mic back to my colleague, Patricia.
Thank you, Dr. Avery. Again, the goal is that by the end of the session, you would have an increased ability to accurately use those key terms related to diagnosis and those clinical features of schizophrenia spectrum and other psychotic disorders, which Dr. Avery walked us through, and then understand how to incorporate an understanding of key features and symptoms while working with individuals in the care process. As Mark discussed, using the case study Darren, but other people that may present similarly to Darren or differently, as Mark discussed, as that can be highly variable between individuals. So let's take a look at a few next steps. Please visit the CARE Act website for resources, including recordings of past trainings and to submit questions and technical assistance requests. I also mentioned the other trainings in this Understanding Schizophrenia Spectrum Disorder series, including a description of institutionalization and criminalization of persons with schizophrenia spectrum disorders, a discussion of course and outcomes, and then a discussion of the APA's guidelines for treatment. There is no wrong door. So if you have a question and you're not sure where it should go or where the answer is, please reach out to us at info@careact.org and we can look to connect you with the right resources. Thanks again and reach out if you have questions.